Hi again, folks. Welcome to the third video on differential diagnosis of language disturbance in adults from Chapter 4 of the Johnson and Jacobson. All right, so this section will focus on diagnosis or evaluation or assessment of individuals with language disturbances. So the etiologies we'll discuss are acute stroke, closed head injury, penetrating brain injury, brain tumor, and primary progressive aphasia. So when we're looking at language, speech, cognitive, and or swallowing disorders, you can see that they actually can co-occur. There's a study by Flowers et al. From 2013 that had a sample of 221 patients, and it found that dysphagia only was found in about 9% of patients in this cohort. Dysphagia and dysarthria together were in about 18.5%, so the largest percentage. So which makes sense because you would expect swallowing disorders and oral motor weakness in coordination, lack of range of motion to co-occur. That's kind of logical. Dysphagia and aphasia were about 7% comorbid. All three occurred in about 9.5%. Aphasia only was 8%. Aphasia and dysarthria was about 6%, and dysarthria only was 8%. So very similar percentage for the most part, except for dysphagia and dysarthria was very likely to co-occur. So cognition. In speech-language pathology, language is often separated from cognition, but really language is a domain of cognition. So language is a domain of cognition, and it interrelates with all other primary domains of cognition. Thus, we should review aspects of cognition and discuss how other cognitive domains interrelate with and influence language performance. So cognition is all the processes by which sensory input is transformed, reduced, elaborated, stored, recovered, and used. So it's a very broad definition of cognition. And generally, we can discuss 5 primary domains of cognition. So attention, executive functions, language, memory, and visual spatial skills. And note that these domains do overlap and intersect. Cognitive abilities are inferred from behavior, and all behavior is multiply determined. For example, poor abstract reasoning performance could be due to attention or memory or verbal expression deficits, a problem with discrimination of stimuli, or a conceptual thinking issue. So it could be really any of those things. Tests and tasks designed to assess specific components frequently do not only test that particular skill, but call upon one skill more than others. So it's always useful for you to think, well, what other skills am I testing when I'm testing this? What am I really testing? And a process approach to determining all factors that might be contributing to performance is necessary. So here's an example, a trail making task. So there are numbers and letters in circles on this page. The directions for the subject or the patient might be, please take the pen and draw a line, alternating in order between the numbers and letters. Start at number 1, then go to letter A, then go to the next number, 2, and then the next number, or the next letter rather, B, and so on. Please try not to lift the pen as you move from one number or letter to the next. Work as quickly and accurately as you can. So what does this assess? In terms of the domains assessed, this could be said to assess executive function, which is tied in with mental flexibility and planning. It could involve language, since it involves letter and number sequences. It involves attention. It involves visual search and processing, and working memory potentially. So of the directions. So there are a lot of domains that are actually being assessed. Executive function, but other things as well. And it is important to note that although certain brain regions are associated with particular skills, the brain has widely distributed overlapping neural networks that work together to perform cognitive tasks. So attention. The ability to maintain a coherent line of thought or action. It's a general definition of attention. So it can be thought of as a complex neurobehavioral capacity without which the expression of all other higher functions of the human brain is impossible. So attention is not a single entity, but a set of brain processes that can interact mutually with other brain processes during performance of perceptual, cognitive, and motor tasks. So this is related to a concept known as arousal, which is the degree of wakefulness of an individual. So this is controlled by the thalamus and the reticular activating systems. Arousal disorders always accompany attention deficits, but attention deficits do not always accompany arousal deficits. When we talk about attention, note that we're constantly flooded by both internal and external sensory input. Without some kind of an attentional filtering mechanism, the brain would be overwhelmed. Forms of attention. So there are passive or non-cognitive forms of attention and active or cognitive forms of attention. So passive meaning it's activated without conscious effort. So this includes the startle response and orienting response. These alert an organism to sudden environmental changes, allow a stimulus to enter awareness, and automatically elicit a somatic or autonomic involuntary response. So, for example, loud noises cause reflexive muscle movements and changes in heart rate. Then there's active or cognitive attention. These include sustained attention, also known as vigilance, selective attention, divided attention, alternating attention, and executive attention. So, sustained attention or vigilance. This is maintenance of a consistent behavioral response during a continuous and repetitive activity, for example, playing bingo. Then you have selective attention. This is enhancing or extending processing of attended relevant stimuli while filtering, inhibiting, or ignoring irrelevant stimuli. So this is associated with being free from distraction. So for example, reading a book in a busy, loud cafe. You're focusing on what you're reading, you're ignoring the irrelevant environmental stimuli around you. Divided attention. This is attending concurrently to multiple activities or multiple components within a task. Note that with divided attention, performance deteriorates with task complexity, and this is known as concurrent cost. An example might be texting while driving. Something you obviously shouldn't do, it's very dangerous, but it is a good example of dividing one's attention between two relatively complex tasks. Alternating attention. This is switching attention back and forth between tasks with different requirements quickly without error. Now, this requires mental flexibility. An example might be listening to a lecture and writing notes. Two different tasks with different requirements. You're doing them both relatively quickly without error, one assumes. And then executive attention. This is also known as attentional control. This is the ability to choose the environmental aspects to be attended to carry out goals. This requires coordination of multiple tasks and regulating our responses with maintaining behavioral goals. So for example, this might be some novel conflict situations, like changing your travel plans given bad weather. You can't get there by plane, so now you have to rent a car. All of the steps that would be involved to accomplish that task might require executive attention. Neuroanatomical correlates of attention. So there is a so-called diffuse attentional system, a DAS, which is a widespread collection of interconnected structures known as an attentional matrix. Now, this diffuse attention involves a large interconnected network across many brain areas. And so that's kind of the idea that there isn't a single focus for attention, it's a diffuse network. That being said, there are some hubs, you might say, of attention. So the thalamus and the cerebral hemispheres. The thalamus is associated with both arousal and attention. Damage to white matter tracts connecting the thalamus and the cortex tend to yield attentional deficits, among other neurobehavioral disturbances. Despite the diffuse distributed neuroanatomical nature of attention, focal lesions can result in attentional deficits. So, your spatial attention span, SAS, this allows for distributed attention to focal spatial stimuli. If a particular point is damaged, there might actually be a resultant deficit in attention, and it might be specific to one particular area or function of attention. Note that the right hemisphere is dominant for attention in most individuals. Therefore, right hemisphere lesions are associated with more frequent, more severe, and longer lasting attentional disorders versus comparably sized and located left hemisphere lesions. Executive functions. This is the highest level of human cognition critical for performance of non-routine, productive, independent activities. So this includes abilities such as problem solving, reasoning, planning, sequencing, organizing, initiating, executing a plan, demonstrating mental flexibility, demonstrating self-awareness, accomplishing goal-directed activities in an organized but flexible manner as demanded by situation or environmental changes. This includes the ability to perceive stimuli from the environment, respond adaptively, flexibly change direction or response, consider consequences, respond in an integrated, common sense way, utilizing all capacities to serve a common purposeful goal. So neuroanatomical correlates of executive function. So as with other functions, there is a diffuse neurological network associated with executive function. That being said, prefrontal regions of the frontal lobes are associated with executive function. However, as with attention, there is no single locus of executive function. Executive function involves a large interconnected network across many brain areas. So a few regions of note, however, prefrontal regions have dense connections with other cortical, subcortical, and brainstem regions. Damages to these areas might cause executive function deficits. One example is the dorsal lateral section of the frontal lobe, which is densely connected to the basal ganglia and the thalamus. Also note that damage to subcortical structures can also affect executive function. So here's a little language review. So form, content, and use. Under form, we have three components. So phonology, morphology, and syntax. So phonology, of course, is the speech sounds or phonemes of a language and the rules for combining them. Morphology is the rules that govern words at the most basic level of meaning, that is the morpheme for a given language. And these include free morphemes that have meaning by themselves, such as cat, jump, swim, and bound morphemes that do not have meaning by themselves. So plural s, past tense ed, present progressive ing, those are bound morphemes. And then you have syntax. So the set of rules that govern word order in a particular language. This allows a rearrangement of words to indicate the same or different concepts. Then, of course, under content, you have semantics, which is our conceptual knowledge, knowledge of meaning, our lexicon. This allows us to abstract particular features of an entity, use these features for organizing the world, and apply symbols to these concepts so we can have a definition of what a mammal is. Maybe it's something that has to be alive, so therefore it must be killed. Potentially it gives birth to live young. Then there's use. Then that includes pragmatics. So this is the permissible way that language can be used. So rules that allow us to use language appropriately, contextual factors like how to enter and exit a conversation, level of formality, how to use humor or sarcasm, implicit meanings or subtext, nonverbal cues, body language. All of these things are pragmatic aspects. Neuroanatomical correlates of language. So as with other complex cognitive skills, language arises from dynamic interaction of multiple anatomical regions. However, the quote unquote zone of language does play a primary role. So typically, the zone of language is thought to include regions of the left hemisphere within the distribution of the middle carotid artery. Uh, it surrounds the sylvian fissure on the lateral surface. It incorporates parts of the frontal, parietal, and temporal lobes. It specifically includes Broca's area for expression, Wernicke's area for reception, the arcuate fasciculus and superior longitudinal fasciculus, white matter tracts that kind of connect these two regions. And just note that the zone of language is not a language center per se, but it is a critical component or a major intersection of several overlapping neural networks that are widely distributed throughout the brain, whose combined activity has the effect of producing language. Also note that pragmatics seem to have a strong association with the non-dominant hemisphere. Now, this is typically the right hemisphere in most individuals. So, memory. So there are several types of memory that are subserved by various brain structures, and the forms of memory depend on ways that different stimuli are encoded, stored, and retrieved. So we've got non-declarative memory and declarative memory. So first, non-declarative memory. This is less accessible to conscious recollection or verbal retrieval. So this includes procedural memory and implicit memory. So procedural memory is like skill acquisition habits. It results from repeated practice. It allows for performance of automatic tasks. We might not be consciously aware of these memories, and they're relatively impervious to decay and interference. For example, they tend to be retained in individuals with Alzheimer's disease. An example might be brushing your teeth or making coffee. Implicit memory doesn't require awareness of learning. No conscious effort to retrieve information. Something that you've seen or heard before just subconsciously influences your performance. There are some studies referred to as priming studies that have shown this kind of an effect, where a subject names syringe, for example, the word syringe faster if the word nurse was presented beforehand, because they're kind of related items conceptually. So this involves generalization of pattern recognition. Okay, now declarative memory. So this is storage of facts that can be stated or discussed, conscious memory. These include episodic memory and semantic memory. So episodic memory is recall and explicit statement of conscious experiences from our personal past. So this is also referred to as autobiographical memory. So perceptual, conceptual, and affective or emotional information. So the smells, the images, how we felt at that particular time. So semantic memory. This is acquisition and retention of generic factual information without reference to a specific learning context. So facts about the world, word and concept meanings, names of objects and people. You could refer to this as Jeopardy memory. So facts, and it overlaps with the language system. Then you have working memory, which is kind of a concept separate from the declarative, non-declarative dichotomy. And this is used for short-term storage and manipulation of new or previously learned info. So this is important for cognitive tasks, things like reading, understanding stories, performing online reasoning tasks. This requires flexible, quick, frequent updating of information. There is a limited capacity. You can only store so much in your working memory. Contents are fragile and they decay quickly. Examples of tasks that require working memory might be mental math, digits backwards. That's a task where one would hold on to info and manipulate it. So 8523, 8523. You say it forwards and then you say it backwards. 8523, 3258. So that's digits backwards. Neuroanatomical correlates of memory. Many brain structures are involved in memory and areas are integrated in complex ways. So that is, all brain structures involved in various forms of memory are reciprocally interrelated. Memory is a system. It has many interconnections. So there are some locations that seem to have involvement, though, with particular kinds of memory. So the hippocampus, which is part of the limbic system, seems to be involved in episodic, semantic, and spatial memory. The prefrontal cortex, however, seems to be involved in working memory And the basal ganglia seems to be involved in procedural memory. So visual spatial skills. These are higher level visual processes that allow us to discriminate, analyze, understand, and manage spatial components of our visual experiences. There's two main components: visual perception and visual construction. Visual perception is the ability to discriminate, identify, synthesize, and analyze simple and complex forms. This allows us to analyze novel and familiar stimuli and interpret what we see. Um, Visual construction combines visual perception with motor responses. So this allows us to mentally or manually manipulate parts of objects and combine them to depict the whole. Uh, for example, perceive and analyze speeds and distances of vehicles to cross a busy street, or drawing a map for directions might be visual construction type tasks. Visual perception deficits will affect visual construction despite intact motor skills due to faulty visual analysis. Also note that poor construction skills can also result from poor motor problems, or can result from motor problems alone, given intact perception. Also note that drawings, status post left brain damage, tend to have intact outer configurations, but missing internal details. Right brain damage tends to yield lack of outer configuration or the whole gestalt kind of a concept, and isolated fragmented details intact. So with left brain damage, you get missing internal details. With right brain damage, you get missing of kind of the whole outer configuration, the neuroanatomical correlates of visuospatial skills. So as this is a running theme here, there's complex interconnections across the brain, but occipital lobe, parietal integration centers are very important for visuospatial skills, obviously. In terms of hemisphere dominance, right hemisphere typically is more engaged in distribution of spatial attention, perceiving and producing the global structure, while the left hemisphere is typically more engaged in perception and production of elements of structures, like within. Visual dissociation and neglect can occur with damage to either hemisphere, but they're more common in right hemisphere damage. Other specific brain areas have been noted to result in visuospatial deficits. So the right corpus striatum, if there's damage to this region, it's associated with deficits of mental rotation ability, so the ability to rotate mental representations of an object in one's mind. And the caudate nucleus and putamen, they receive direct input from parietal regions that are important for integrating visual perceptual and visual construction processes. So it makes sense that damage to either of these regions would also result in visuospatial deficits. So let's talk a little bit about an assessment procedure. So first, one would do a screening. You might be referred to the patient by some health professional, and you might do a brief check of an area of concern. So speech, language, voice, swallowing, etc. If deficits are noted in the screening, if they don't pass the screening, then you proceed to the assessment. Okay, and then at the assessment level, you might read the client history, do a medical chart review, look for the doctor's summary statements, imaging results, prior speech therapy notes, etc. You might interview the client, family, or other caregivers for information. And through the assessment, you're going to determine the patient's perceptions, their goals, their strengths, their weaknesses, any relevant background information that could add to the picture. One should always consider the veracity or the truthfulness of the source. Given a particular medical diagnosis, they might be likely to be an unreliable historian. You want to also determine their prior level of function. This will help you make a strong argument for skilled speech therapy for insurance approval. You might complete a formal or a standardized test where you're assessing and measuring deficits in a standardized way and comparing to what would be expected in a quote unquote normal or neurotypical individual. You might do an orofacial or oral mechanism examination as appropriate. You will likely do some informal or ecological assessment as well, language sampling in kind of more natural context. You might do a test of stimulability or dynamic assessment. Can the patient improve given modeling or prompting? You try different kinds of prompting, different amounts, trial different therapy types. What kind of prognosis might the client or patient be expected to have? How much support do they need, and how much better do they get with a certain amount of support? So, with a process approach, this refers to a diagnostic mindset in which all aspects of behavior are carefully observed and recorded during an evaluation session. So you want to record correctness and incorrectness, but other factors are also important. So things like how long the patient takes to respond, the nature of their errors, how subsequent responses might relate to previous ones, like, for example, is there perseveration? Is one input modality better than others? Do they do better given auditory versus written input? Um, are there any environmental or contextual variables, things like background noise, presence of others, family members or other patients or other caregivers, uh, nonverbal cues, delivery rate and loudness? Are there psychological factors that you should be aware of? All of these things should be kind of taken into your uh, clinical thinking machine, and then kind of figure out what the best approach would be given all of this data. So you use this information to determine what needs to be probed further. Like what's the level and the type of prompting that's needed also. These are important things to determine. The speech language pathologist should be aware what cognitive linguistic processes are required by a particular task, as I mentioned before. So for example, does the task rely on verbal working memory, visual construction skills, both? What are the stimulus characteristics and response requirements? If this is the stimulus that you're providing to the patient, is it spoken? Is it written? Is it drawn? Is it multiple modalities? Perhaps you should consider the possibility of hearing loss. And they may not be able to communicate that they have one, and it might not be in the history. It could be, but it doesn't necessarily have to be. If it's a visual stimulus, consider is it an actual object? Is it a realistic picture? Is it a line drawing? Is it an abstract image? Consider vertical versus horizontal alignment, object size, color, contrast. Consider patient visual deficits. Um, Consider complexity. Is it a simple versus a complex stimulus? Are there any atypical patient behaviors that you notice before, between, during, and after tasks? You should always be asking yourself, where is the deficit? Is it language, speech, cognition, swallowing, multiple deficits? What are the patient's goals? Do they want to go home with complete independence? Do they want to go to an assisted living facility, a long-term care facility? Where do they want to go? Can we get them there? How much support will they need? Can they go home alone feasibly? Or are they able to go home with their family member or spouse or with home health? And what is their prior level of function? Is this a pre-existing problem or is this new? How much worse are they now than they were previously? Here's an example. So a female patient with post-stroke aphasia was given the Boston Diagnostic Aphasia Exam 3, the BDAE-3. Single word auditory comprehension subtest has certain stimuli, such as show me the bear. The patient then points to the correct picture in a field of 4. So what does this test besides auditory comprehension? That is, what does one need to know to do this task? Does it require the linguistic skills to comprehend the task using semantic knowledge of what a bear is? Certainly. Does this require the visual skills to accurately identify a bear from the field? Of course. Does this require motor skills to point to the correct item? Yes, all of the above. So what if the patient responded correctly to only 6 out of 30 auditory comprehension subtest items, but responded to yes, no, and open-ended questions and performed word repetition with high, consistent accuracy prior to the standardized assessment? Does the patient consistently perform non-visual tasks accurately? Could there be a visual deficit rather than an auditory comprehension deficit? Gather information about the visual deficits. Could there be some type of a macular degeneration, or did they just have their glasses left at the hospital? Do we need to test visual skills further? Is there allocentric or egocentric neglect or field cuts? These are things that you should always consider. Does patients' accuracy fluctuate from the morning to the evening, from day to day? throughout the week. Could this be due to disease process, sundowning, medication changes or adjustments, medical status changes, irregular sleep patterns? These are all things that we have to consider. Okay, so let's talk a little bit about formal or standardized assessments. So these are tests that are criterion referenced. So they're comparing a client score to some type of criterion. Does the client pass this particular criterion, this particular level of function? So one example might be the slums, which is a cognitive assessment. If the patient gets a score of 27 out of 30 or higher, they are presumed to be within functional limits. For example, that's a criterion referenced versus norm referenced, where we compare a client score to an average score of peers and their standard deviations above and below the mean. And then you say, is the performance below that of same age peers? Yes or no. So standardized assessments are targeted towards specific populations. So whatever diagnostic tool you decide to use, make sure that it is used appropriately. You're using it for the patient population that it's designed to be used for. So for example, the Western aphasia battery is for adults with suspected aphasia versus the BADS. The behavioral assessment of this executive syndrome is for adults with TBI and executive function deficits. So you need to interpret individuals' performances on formal assessments carefully. That is, think why they might have done poorly on a particular task and look for patterns. Assessments should include tests of both language and nonverbal communication. So here is a table from your book with a number of standardized assessments for evaluation of language components. And so here you can see Boston Diagnostic Aphasia Exam, the Western Aphasia Battery. There's quite a lot of them. I'm familiar mostly with the Western Aphasia Battery. That's the exam that we use more than any other in my particular facility. And that includes the spontaneous speech. So you might ask the patient, how are you today? What's your full address? Why are you here in the hospital or in the nursing facility? And then you give them points for meaningful responses, complete responses to assess fluency. There might be auditory verbal comprehension, yes, no questions, such as, is your name Smith? Is your name Brown? Is your name blank? Are there lights in the room? Are you a doctor? Is the door closed? Then you might do sequential commands, such as point to the coin and the pen, point with the pen to the paper. So there are kind of two-step questions, two-step sequential commands, and they get a point for each component. Repetition tasks. Yeah, repeat these words, say bed, say window, say 45. There's object naming, so common objects you might find around the room. So bed, telephone, pillow. What color is your shirt? What is this? Like elbow, different things that you have them name. So what is this, or what is the name of this object? And you might have them read, you might have them write a little bit. And there's also an apraxia, an optional apraxia component as well. So it has quite a lot of components there. So that's the Western aphasia battery, but there are quite a lot of other diagnostics, and it is good for you to explore them and figure out which diagnostic assessment might be best for the patient population which you typically see. Okay, a little bit about informal assessments here. So informal assessments are usually something created specifically for the client. You're asking them particular questions that are relevant specifically to them. It's not standardized, it's more subjective. It can be very useful, but you obviously can't compare the results to other clients or peers. An example might be language samples. And then there's a dynamic assessment, which the whole point of dynamic assessment is to determine how much and what type of assistance or prompting supports the client's highest level of performance. So how much prompting do they need and what amount of prompting is best? Okay, so when we're looking at informal assessments, they can include all of these types of tasks here. This is from the book again. You might have a discourse sample, assess auditory comprehension, have identification, so object ID, body part ID is good. You can have objects that you can bring in and have them name them, common objects such as money. You can assess naming skills of various parts of objects. You can assess repetition of short, simple, and then more complex multisyllabic words and phrases. You can assess reading or writing. You can assess pragmatic skills, so waving goodbye, uh, using a hammer to pound a nail, sticking out your tongue, blowing out candles. Singing might be a good way to go, especially if you're looking at potentially doing a dynamic assessment for melodic intonation therapy, say, for example, if it's an aphasic patient that you're going to trial that with. Then there's nonverbal cognition. So to assess nonverbal cognition, you might look at a perspective memory task. You might do clock drawing, line bisection, various graphomotor patterns, figure copying and drawing. There's a cube drawing task in the MOCA that's pretty common. Visual memory, pointing span, simple trail tasks like we discussed previously, generating novel sequences of 3 items, perspective memory. There's all these different kinds of tasks that you can assess. And if you have plenty of time, if you're in like a long-term care facility, you might be able to really dig into some of this stuff and really find out specifically what their nonverbal cognitive deficits are. So let's get into etiological groups now. So first, let's talk about sudden onset or acute disorders versus slow onset disorders. So some degree of recovery is expected with acute onset disorders, while with slow onset disorders, there is an expected continued decline. Now, sudden onset disorders include things like stroke, traumatic brain injury, anoxic events, and slow onset disorders include brain tumors, primary dementias with language deficits and without deficits, and then neurodegenerative neuromotor disorders. Note that the left hemisphere is language dominant for about 99% of right-handers, and the left hemisphere is dominant for about 65 to 70% of left-handers. With traumatic brain injury, language and cognitive deficits depend on locus and severity, where it is and how big the injury is. So acute onset stroke in the language zone. So this would include aphasia. So aphasia is an acquired language impairment resulting from damage to the brain. So acute stroke and language dominant, usually left hemisphere, will likely result in aphasia if the areas within the language zone are damaged or disconnected from other brain regions. The language zone includes Broca's area, Wernicke's area, the angular gyrus, the supramarginal gyrus, and the neighboring regions fed by the middle cerebral artery. A cerebrovascular accident or stroke within the left MCA territory, even if it's subcortical, can result in aphasia. So damage anterior to the central sulcus will probably result in expressive deficits, with comprehension being relatively intact. If there's damage to the motor strip, hemiparesis or dysarthria might occur. Damage posterior of the central sulcus probably will result in auditory comprehension deficits with fluency intact. Motor deficits are less likely. Note that the various and sundry types of aphasia are presented here in this table 4.5 from the textbook. There's the non-fluent aphasia syndromes and the fluent aphasia syndromes. Non-fluent aphasia include Broca's, transcortical motor, and global. Fluent aphasias include Wernicke's, conduction, transcortical sensory, and anomic aphasia. So you can see that there's various language features. The non-fluent variety tend to be non-fluent. They are agrammatic, kind of halting, broken speech, paragrammaticisms. And fluent aphasia tends to be potentially neologistic. Fluent, paraphasic, empty speech is very common in these types. So note that components of both expression and reception may be differentially spared or impaired in diverse ways in all major varieties of aphasia. This table you see on the right is table 4.5 from your book. This includes the Boston classification system of aphasia. And there are 7 basic types of aphasia under this classification system. Note that a patient may not fit perfectly into one of these categories. That being said, one is to focus on their strengths and their weaknesses. You want to address the patient's weakness and capitalize on their strengths. A stroke affecting the language zone, resulting in aphasia, often results in cognitive impairments and executive function and visuospatial processing issues as well. However, not all patients with acute stroke resulting in aphasia will have executive function deficits. A patient with aphasia may or may not have nonverbal cognitive deficits. Memory is not typically affected in aphasia-producing strokes, but deficits in short-term verbal encoding, retrieval, and verbal working memory are not uncommon. In fact, you could actually consider aphasia to be described as impaired word memory. Word finding difficulties are often interpreted as memory issues, but aphasia is very different from general memory impairment. Acute onset stroke in the non-dominant with respect to language hemisphere. So deficits status post non-dominant hemisphere stroke include difficulties interpreting metaphorical language, aspects of social communication, poor interpretation or production of emotional prosody, poor recognition and production of melody, various degrees of spatial inattention or neglect on the left side, which may affect reading and writing, anosognosia or reduced awareness of deficits, possible dysarthria, especially if extensive damage to the cortical motor system occurs. Unilateral upper motor neuron damage, though, does not typically result in persistent dysarthria. Cerebellar strokes result in what's known as ataxic dysarthria. This is not uncommon. It is not uncommon for cerebellar lesions to yield executive function impairments due to extensive connectivity with other brain regions. The right cerebellar hemisphere may actually have a role in verbal fluency and verbal working memory. There are connections that exist between the language areas in the left cerebral hemisphere and the right cerebellar region. Brainstem strokes are highly variable and might yield changes to consciousness, swallowing, motor function, speech production. They could even result in death in some cases. However, these strokes are not likely to affect language unless combined with hemispheric strokes and language zones. All right, traumatic brain injury or TBI. Note, each TBI is different. Therefore, it's virtually impossible to describe the observed, quote unquote, typical acquired language or cognitive deficits. The damage from a TBI is likely to affect many domains of cognition and less likely to result primarily in a language deficit than other etiologies. Varieties of brain damage and sudden onset TBI include diffuse or widespread injuries, such as in a motor vehicle accident or a closed head injury, focal or localized injury, such as a bullet or penetrating head injury, blast injuries, for example, explosions or military injuries, and injuries from repeated blows to the head, such as chronic traumatic encephalopathy, CTE, found in boxing, football, and other sports injuries. So closed head injury. This is commonly seen in motor vehicle accidents. So the brain is moving at a high speed, then comes to a sudden stop. The fluid-filled meninges provide some protection, but the brain might hit the interior aspect of the anterior skull, which has many bony protuberances. And this is referred to as the coup injury. It's that first injury when the brain hits the inside of the anterior portion of the skull. As the brain reacts to this injury, it might also recoil and hit the opposite side of the inner skull. And that's a counter coup injury. So coup, counter coup. These impacts may result in cortical bruising, focal damage at deeper levels, intracerebral hemorrhage, and even diffuse axonal injury. Now, this is when the cerebrum twists upon the brainstem, stretching and tearing a large number of neuronal axons diffusely throughout the brain. So the combination of local and diffuse injury observed in closed head injury frequently results in significant cognitive and linguistic deficits affecting communication. So you can have things like memory deficits, anomia, word finding problems, behavioral symptoms such as impulsivity, dysexecutive syndrome, social pragmatic deficits. These are all common status post frontal lobe damage. Then we have penetrating head injury. And penetrating head injury The brain is damaged by an object, a knife or a bullet, a projectile that breaks through the skull and the meninges and enters the brain tissue. So the severity of the penetrating head injury depends on the size and force of the object entering the brain. This may be exacerbated by secondary consequences such as infection, bleeding, changes to the circulation of cerebrospinal fluid. There is a possibility also of the patient developing a seizure disorder as the brain reacts to the scar tissue that forms in the region of the injury. The patient might need to be placed on anticonvulsant meds as a reaction. The patient might require a craniotomy or a shunt to manage the brain swelling. And the physical and behavioral effects depend, as I mentioned before, on the brain regions damaged by the projectile. And these are highly idiosyncratic. Every penetrating head injury is different. Okay, blast injuries. These commonly result from explosions during military conflicts. They can result in deficits in the areas of speech, language, nonverbal communication, swallowing, hearing, and they are complex because damage is caused by a pressurization wave of the blast as well as shrapnel. So there can be multifocal injury, multiple body parts can be injured, and there can be both diffuse and focal brain injury as well. Brain concussion and post-concussion complaints are common in less severe injuries, in less severe blast injuries. There can be difficulty with memory and concentration, headaches, bradyphrenia or slowed thinking, irritability, depression. Some of these symptoms actually overlap with PTSD and they might be misdiagnosed as such. Primary language disorder is less common with blast injuries, but it is possible. One example was a gentleman, Bob Woodruff, who was an ABC newsman who suffered a left hemisphere blast-related injury. Chronic traumatic encephalopathy, CTE. This is the consequence of multiple brain injuries that are commonly sustained in sports like boxing or football, where athletes will experience multiple concussive events over the course of their career. So this is associated with the term dementia pugilistica or pugilistic dementia or punch drunk syndrome that's observed in some boxers that are entering their middle decades or older years. I'm not sure if you're familiar with Muhammad Ali, but he had what was referred to as pugilistic dementia as he grew older, and he lost a good amount of his cognitive and linguistic skills. That being said, language disorders may not be common in CTE, despite relative frequency of dysarthria and cognitive deficits, for example, memory and executive function issues that are associated with it. So sudden onset anoxic or hypoxic event. So this is caused by lack of oxygen to the brain in a variety of situations. So for example, complications during heart surgery, sleep apnea, chronic obstructive pulmonary disease, high altitude exposure sickness, drug overdose, diving and drowning accidents. So the brain is deprived of oxygen for some period of time. One article by Fitzgerald et al. In 2010 found that speech and language deficits are common. They were actually found in 75% of individuals in a particular review study, There's typically poorer outcomes with anoxic or hypoxic events than in TBI. Okay, brain tumors. Tumors can arise from cerebral tissues, gliomas, from cancerous growths elsewhere in the body that have metastasized or spread to the brain. They can occur from meningeal protective layers surrounding the brain. I had a friend who had a close family member that had a meningioma that required operation, and she actually had developed a seizure disorder following that and has to be on anti-seizure, anticonvulsant medications. And the complications of the anti-seizure medications are actually that she has a kind of a resting tremor now. And with tumors, as the tumor grows in size, it may impinge upon brain regions near it and impair function. This is sometimes referred to as a mass effect. Tumors may be malignant, cancerous, or benign, non-cancerous. If the diagnosis is malignant, then there will likely be more pervasive surgery, potentially radiation and or chemotherapy, depending on the TNM level, the tumor node metastasis level, or the cancer stage. Language function may also be affected if the intervention, such as the surgery or the radiation therapy for the tumor, results in damage to parts of the language zones. So sometimes the actual treatment can result in deficits. Sometimes initial symptoms of developing a tumor are language symptoms that slowly worsen over time as the tumor grows. This is word finding deficits are common in this kind of a situation. So tumors in Broca's and Wernicke's areas can mimic symptoms of these aphasias, of anomic dysphasias. The patient may require frequent reassessment to check their current status as the various stages of intervention are carried out. Therapy might be interrupted due to other aspects of medical care, such as surgery, radiation therapy, chemotherapy, and you must always consider the cognitive effects of these treatments. And there might be a likelihood of the patient developing a seizure disorder as well. So, slow onset dementia is affecting language and cognition. So, dementia. Dementia is characterized by progressive deterioration of cognitive functions, changes in personality, and impairment of social functioning. Dementias with language disturbance include Alzheimer's disease, primary progressive aphasia, and vascular dementia. So, Alzheimer's disease is the most commonly diagnosed dementia in middle aged and elderly adults. There are several types: later age related AD and early onset AD, and there are some other subtypes as well. The first symptom in Alzheimer's disease is typically a memory disorder, followed later by language deficits. In brain scans, patients with Alzheimer's disease sometimes show neuronal loss and atrophy of the medial limbic regions, leading to memory impairment, followed by cortical atrophy in the temporal, parietal, and frontal language zones, which those lead to language deficits. But anomia is often the first language symptom to develop. Yes, buddy, that's my cat. Mild cognitive impairment refers to a pre-dementia condition with signs and symptoms that are greater than normal aging, but less than dementia. Aspects of early, middle, and late stage Alzheimer's disease are elucidated in the table here. You can see early stage mild Alzheimer's disease, middle stage moderate AD, and late stage severe AD. You can look over those, but generally speaking, the person with mild AD will be fluent, will articulate it, have grammatical verbal output. Language is not very much affected, but there will be issues with memory that are somewhat, mild. And then in the middle stages, changes become more obvious. They're different than normal aging. Verbal output becomes anomic, circulatory, tangential. There are paraphasias, some neologisms, so made up words, oral reading, auditory comprehension issues. And then in late stage, all language and cognitive abilities are severely impaired. It might even eventually result in mutism. So it's a progressive progression from early to middle to late. If it's a significant nonverbal fluency of verbal output dementia, then it's probably not Alzheimer's disease. Language typically remains fluent, albeit impaired, tangential, and perseverative. Late stage dementia. In late stage dementia, language and all cognitive functions are profoundly impaired, and eventually there might be a lack of communication completely, a mutism. Primary progressive aphasia, also known as frontotemporal dementia. So this refers to a family of neurodegenerative disorders in which progressive language impairment is prominent. So neuroanatomically, this is associated with frontal and temporal lobe atrophy. Disease progression typically begins at younger ages in Alzheimer's disease with a more rapid course of deterioration. It's often diagnosed if language deficits are primary for a period of two years, if other cognitive functions are intact, and if other causes for language deficits have been ruled out, such as stroke or tumor. And there's 4 main types of these. Vascular dementia is dementia caused by cerebrovascular origin. So that is, the patient has often sustained multiple strokes or a series of large vessel or small vessel strokes that together have resulted in enough impairment across cognitive domains that the criteria for dementia have been reached. So that means the dysfunction in more than one cognitive domain, changes in personality and behavior, and impairment of social functioning. Often, the cerebrovascular disease is difficult to control, and the patient is at risk for increasing brain damage due to subsequent strokes. For these individuals, vascular dementia is progressive. However, not all individuals with vascular dementia have progressive impairment if the disorder is well controlled. Note that memory is always impaired in Alzheimer's disease, but only sometimes impaired in vascular dementia. It's always progressive with Alzheimer's disease, but only sometimes progressive in vascular dementia. There are multiple patterns of vascular dementia. You can have multiple cortical infarcts of multiple sizes. You can have a lacunar state resulting from multiple small infarcts in subcortical regions. You can have something known as Bisphenger's disease, multiple small infarcts in the subcortical white matter that's related to hypertension often. You can have CADASIL, which is a rare inherited form of vascular dementia. Note that the diagnostic label is not enough. SLPs need the imaging report details to discover the locus or the loci of the brain injury, as well as information from behavioral assessment. If there's language zone damage, you could expect language impairment. If there's cortical damage, you can expect apraxia, agnosia, dysarthria, hemiparesis, hemisensory impairment. If there's subcortical damage, you might ask, what is the function of the damaged region? If it's in fiber tracts, well, what do the fiber tracts connect? What can I expect regarding deficits? Dementia with Lewy body. This is a dementia syndrome that eventually includes Parkinsonian movement, a Parkinsonian movement disorder component. So the person might actually receive a diagnosis of Parkinson's disease dementia. But if dementia presents first or simultaneous to movement disorder, then the patient might receive a diagnosis of Lewy body dementia. Note that dementia with Lewy bodies, the symptoms are progressive mental impairment with attentional and visuospatial difficulties, fluctuations in cognitive function, persistent well-formed hallucinations, and spontaneous motor features of Parkinsonism. So hypokinetic dysarthria, tremor, bradykinesia, gait, balance difficulties, this particular symptom profile. Late stage dementia with Lewy bodies appears similar to Alzheimer's disease with deficits in memory, other cognitive domains, and possibly language deficits as well. Note that memory is typically worse in Alzheimer's disease, while visuospatial function is typically worse in dementia with Lewy bodies. All right, and that ends video 3. Thank you so much for watching, and I will see you next time.